Thanks, Daryl, for the introduction. Welcome, and thank you for attending this presentation on earlier recognition of critical illness outside the ICU. I'm Dr. Frank Sebat, and I'm going to emphasize in today's talk back to the basics, back to the bedside, in which I think all further improvements in failure to rescue is likely predicated upon. So what's the problem in recognizing these patients earlier? Well, first of all, hospitals are relying more and more on early warning scores. This leads to the idea that early warning scores are really the first indication of decline. However, in reality, the early elements of decline that are part of the early warning score are frequently incorrect, making the score less valuable, particularly respiratory rate and mental status. It's like having an altimeter in a plane. You can rely upon it if you're not paying attention, but if you're looking out the window, you're likely going to know that you're getting close to the ground far sooner than the alarm will go off. I think early warning scores are very analogous to this. In addition, a lot of resources are spent on these scores with less focus in resources for educating nurses on how to accurately perform a good bedside exam and what it means. There's an inherent delay in early warning score once it's activated because you have to re-examine the patient to understand the pathophysiology responsible for its trigger and what to do about it. In addition, there's more institutional focus on calculating the score than actually getting accurate acquisition of its elements. Early warning scores are widely utilized, and they're a valuable safety net for patients. But how can we improve upon this process? Well, what if we implemented an early warning bedside assessment? Well, you might say, well, what in the world is that? Well, in the example I'm going to present that I refer to as the 10 signs of vitality, because it's a brief head-to-toe exam that's comprised of 10 vital signs, and it's used to assess the patient at the beginning of each shift and when there's a new vital sign abnormality or the nurse becomes concerned during their shift about the patient. It's also utilized to activate the IRT when criteria are met, and I'll go into that later. It's been proven to be effective and implemented at 3 hospitals in Northern California where I've worked. It's comprised of 4 hours of paid nursing education, 1 hour didactic, 2 hours of lab bedside experience, and a 1 hour exam and Q&A period. This is our formal 4-arm rapid response education, and all general ward ED nurses and non-ICU nurses are required to go through this educational program. It's focused on the bedside nurse, who's the most important component of your rapid response system, not to diminish the role of the RRT. But it's important to point out that a well-trained, highly functional RRT arriving at the bedside late in the course of a patient's illness is going to have less impact on improving outcomes than an average rapid response team arriving very early at the bedside of a patient who's deteriorating because the bedside nurse noticed there was a problem. This program emphasizes the importance of the key bedside abnormalities. What is the significance of the pathophysiology and what actions are needed to reverse it? Particularly focuses on the accurate acquisition of the non-automated vital signs, that is respiratory rate, mental status, and capillary refill time. There's ongoing institutional efforts that are absolutely key to assure that the competency and compliance of the program participants continue so that the system continues to improve and functions well. Once the early warning assessment is performed, the physiological abnormalities identified, if any, are linked to protocolized interventions. The 10 signs of vitality early warning assessment is comprised of 10 vital signs. 11 parameters as temperature, both hyper and hypothermia, are utilized differently. The reason the 3 major vital signs identified here are so important is that the earliest sign of decline. but they're also non-automated and the ones that are most subject to error in their acquisition, respiratory rate, mental status, and capillary refill when prolonged. The 5 additional major vital signs are very important, but they occur much later in the course of illness, including hypoxia, hypotension, hypothermia, oliguria, and when available, increased lactic acid or base deficit. The minor vital signs of fever, change in heart rate, or pain are important to prompt more evaluation of the patient and to repeat a 10 signs of vitality assessment. But if they are the only parameters abnormal, your patient's not at risk. If you have only one parameter that's abnormal of the 8 major, you're still likely not to be at much risk, but you should watch the patient more closely. And if 2 are abnormal, you're definitely at risk and should mobilize the RRT. So I'm going to discuss the 10 signs of vitality track and trigger early warning assessment as it's utilized to determine whether your patient is or not at risk and to launch the rapid response system. It's also used to classify your patient as either a primary oxygen deficit or a primary perfusion deficit, and it requires the initiation of AOV IPPS resuscitation. Now, if you have a single abnormality, you're at low risk. And you have time to sort through this with the primary care team. If you have, let's say, 2 abnormalities, but one is minor and one is major, you're still at low risk. But if you have 2 abnormalities of the major criteria, then you either are going to have a significant hypoxic event or a significant perfusion problem. And depending upon which abnormality, for example, hypotension and oliguria versus, let's say, arterial hypoxemia and low respiratory rate would represent a primary oxygen deficit. You start out by securing the airway, in that case, nasal trumpet, nasal suctioning, jaw thrust, supplementing oxygen as appropriate, high flow and so forth, and supporting ventilation with BiPAP, etc. If you have a perfusion deficit, AOV is still the first steps. And you might say, well, why is that? It's a perfusion problem. Well, it's really because supporting the respiratory system reduces the work of breathing. And that blood that's going to the increased work of breathing in any hypoperfusion state can now be redirected to more vital organs like the brain, heart, or kidneys. Hypoperfusion persists after AOV. You infuse volume, figure out what's wrong with the pump. Do I need pressors? Do I need inotropes? Other pharmacologic support like antibiotics for sepsis or steroids for anaphylaxis, and what specific interventions might be helpful like endoscopy for GI bleeding and laparotomy for perforated viscus. So if you empower the nurse with an early warning assessment, through education, competency measures, you're going to increase the chance that, number 1, their assessment's accurate. 2, that the nurse will have increased confidence that their patient is or is not at risk in real time when they're examining the patient for acute decline. And it also understands or also causes the nurse to be able to act upon in real time any significant abnormalities. However, even with an early warning assessment, there's some pitfalls that need to be addressed for this to be effective. So number 1, the problem is the scale we use to evaluate mental status. GCS is most often used. It's never meant for mental status. And you could have a patient who is oriented ×3, opens their eyes, obeys command, can still be very anxious or agitated, and it could be a new sign of sepsis or respiratory issues, etc. This scale was not meant to evaluate mental status. It was really to evaluate patients who are receiving sedation and narcotics. But in fact, it's the best scale available. And if you use the RAS and said alert and calm is normal and anything else is abnormal, it would be much better than using GCS. Okay, a scale that I created is called the 4AVPU. To refresh your memory, the AVPU scale refers to being alert and normal versus responsive to verbal only or pain only or unresponsive. By adding agitation, anxiety, and apathy, these are parameters which are much earlier detectors of change in mental status that are neither captured by the AVPU scale or the GCS. Apathy is not captured by the RASS scale. So we use this in 4 Northern California hospitals along with the 10 signs of vitality, and coupled that to the protocolized interventions that I've gone over before, and it resulted in improved outcomes at the 4 institutions. This is currently in press in critical care explorations. Respiratory rate is the sentinel sign of clinical decline. Unfortunately, it's often estimated, and at worst, it's fabricated. And it also continues to surprise me that clinicians often think that the increased respiratory rate associated with critical illness, particularly in the case of sepsis or septic shock, is the onset of metabolic acidosis. In fact, this is incorrect. As the respiratory rate goes up early in sepsis or early in respiratory insufficiency, it is usually accompanied by a drop in PCO2 with the hyperventilation, giving rise to a metabolic alkalosis, and the oxygen saturation frequently is increasing because there's more room in the alveolus for oxygen as the PCO2 drops. It is later in the course of respiratory insufficiency or hypovolemic shock, sepsis, etc., that the respiratory situation starts to deteriorate to the point that the respiratory system no longer compensates. Patient becomes hypoxic, very tachypnic until they can't breathe anymore and have a near respiratory arrest, and is associated with a respiratory acidosis in addition to a metabolic acidosis. So how do we know we have a problem with the respiratory rate? Well, there was an article published in British Medical Journal Quality of Safety in 2017 where it was entitled, "Is Everyone Really Breathing 20 Times a Minute?" And in this study, they were able to demonstrate that although the heart rate of the same patient population had a normal Gaussian or bell-shaped curve, the respiratory rate didn't. It was centered on even numbers and clustered around 22, 20, and 18. Now, the hospital I work at, I went to the IT department, and in about 5 minutes, they were able to plot out this histogram of 25,000 respiratory rate observations, and it looks more like the Sears Tower than it does a Gaussian distribution. You can see here that at our hospital, everybody was either breathing 16, 18, or 20. Nobody had an odd respiratory rate, and very few people had elevated or low respiratory rates. I think that this is very strong evidence that respiratory rates are estimated, and they are determined, their value based on a bias towards normality. You can see I'm going to pull up my respiratory rate app, which has a picture of a child, and it asks me to observe the child and tap the screen on each inhalation, which I'm going to do now. So in less than 30 seconds, it was able to capture a respiratory rate at 25. So the algorithm allows for an irregular respiratory rate. And then, of course, I can do it again or exit. So pitfall number 3, capillary refill time. It's easy to do. It occurs or is prolonged long before hypotension occurs in hypoperfusion states. If you dichotomize it, it's pretty simple to figure out that greater than 3 seconds is representing decreased perfusion to the extremity in a prolonged capillary refill. It's very predictive of decline despite inter-observer variability, and it's very helpful but not utilized. And I'm going to show you some reasons why I think it ought to be utilized. In an analysis done by my colleagues and myself, looking at the 11 parameters within the 10 signs of vitality and how they correlated to mortality of RRT patients. And you can see in descending order of importance is that hypoxia in the setting of increased oxygen requirement was most predictive of death. Capillary refill, somewhat surprising to me, was second most important, followed by hypotension, etc. You can see at the bottom that if the patient was in some way able to communicate to the clinicians that they were having new or significant pain or fever, they actually had a reduced mortality. So that alludes to the fact that fever, in the case of sepsis, is actually predictive in somebody who is recognized to have sepsis. So I want to go over the Andromeda study because it really emphasized the importance of using capillary refill time compared to lactic acid as for targeted resuscitation of a patient. The problem with lactic acid is that early in sepsis or shock, it isn't up because it's in the tissues and hasn't been washed out into the circulation. And so you may have a level that is low in the blood but high in the body. Conversely, you may have a patient who has cleared it out of the tissues, but it hasn't been cleared out of the blood or metabolized by the liver, and it's elevated in the blood but not elevated as much in the tissues. And therefore, it's a late sign. On the other hand, capillary refill is a real sign of perfusion to the extremities in real time. If it's slow, the perfusion to the extremities is slow. If it's brisk, the perfusion to the extremities are brisk in real time. In this particular trial, when they looked at resuscitating patients to the endpoint of normalizing or improving their capillary refill time compared to improving their lactate, they required less fluid, there was less multi-organ failure, the hospital length of stay was less. The mortality in the entire population almost reached statistical significance, but if you looked at the subgroup of patients who weren't as sick, the mortality was significantly less at 20.4% versus 39.4% of patients who had targeted resuscitation to lactate. So it's a more accurate real-time measure of perfusion than lactic acid, which makes it compelling to be using it as part of your examination. This is an example of normal brisk capillary refill time. And you'll notice after moderate pressure on the pulp of the index finger in less than 2 seconds, it returns to normal color. So this is an example of delayed capillary refill time. Because of technical difficulties, I couldn't play the video, but you can see after 4 seconds, the tip of the finger was still blanched after moderate pressure. So pitfall number 4, temperature. So this looked at 64,000 ED visits, of which almost 700 patients had community-acquired sepsis. What of note here is that the hyperthermic population had the lowest mortality, but it only comprised 26% of the patients. So the idea that fever is a good identifier of somebody who is possibly septic is not really true. Matter of fact, the vast majority of patients who are septic are normothermic, and their mortality is more than twice the hyperthermic group and 3 times higher mortality if they're hypothermic. So you need to understand that a normal temperature is not helpful in identifying a patient. And in fact, if you suspect sepsis and you're normothermic, you're at much higher risk. Okay, the good and the bad of an early warning assessment. Well, first of all, the good is if you do it, you most certainly will reduce morbidity and mortality. Some of the problems we've talked about: respiratory rate, both high and low, is a sentinel sign of decline, but respiratory rate is guesstimated. It's almost never measured, and it's biased towards normality. Change in mental status, a very early sign, but those early signs of alterations of mental status are not picked up by GCS. Capillary refill time is incredibly important and occurs in terms of being prolonged much earlier than hypotension or elevated lactic acid. I don't think this is appreciated, and when it is measured, it's frequently not utilized within a score. And regarding fever, actually you should be happy if you think your patient's septic and they have one, because it's protective. So use a phone app or a stethoscope so you can actually capture the rate correctly while you don't have to look at a timepiece and the patient at the same time. Use the RAS or the 4-AVPU scale for mental status. Incorporate capillary refill time into your risk assessment. Who's going to fix these issues that we've discussed? Well, you are. And if you take these concepts back to your institution and complement your early warning score with the early warning assessment, I think you'll like it, and for sure your patients will. This is the bibliography. And if you email me at fsebat@aol.com, I'd be happy to send you the articles. Thank you.